Okay, now let's talk about calcium imbalances, and I'm probably going to go ahead and talk about phosphorus imbalances in this same sitting. With calcium imbalances, again, clinical manifestations, looking at nursing diagnosis and looking at the nursing interventions, and my slides, my notes, everything follow very well with your text reading, especially in Lewis. So with hypercalcemia, hyper meaning high calcium in the bloodstream, greater than 10.2 milligrams per dil. Then we have hypocalcemia, which is less than 8.6 milligrams per dil. And yes, you have to memorize these values. So with hypercalcemia, we will see lethargy and weakness and fatigue. And again, you're noticing that there's some similarities. Learn your similarities, but then pick out what your differences are. So with hypercalcemia, we'll have decreased memory, depressed reflexes, meaning your deep-tinted reflexes. Some of you will have increased blood pressure, confusion, maybe some psychosis. And you may think, man, what's going on with this patient? Anorexia, meaning doesn't feel like eating, poor appetite, nausea and vomiting. Because of having hypercalcemia, this is meaning that the calcium is not in the bones where it should be. Okay, so therefore your bones are nice and brittle. So you can have bone fractures, polyuria, which is increased amount of urination and dehydration, nephrolithiasis, which is kidney stones. Okay, nephro meaning kidney, lithiasis is stones. And seizures and coma, and then this can lead to ventricular dysrhythmias. As I said in previous lectures, a lot of our electrolytes can manifest into cardiac problems. Hypocalcemia will have the weakness and the fatigue, depression and irritability, confusion, okay, hyperreflexia. So with hypercalcemia, we have depressed reflexes. With hypo, we have hyperreflexia and muscle cramps, decreased blood pressure, numbness, tingling in extremities in the region around the mouth. This is a big key factor with hypocalcemia. If your patient starts complaining of numbness and tingling, a lot of times we'll see this after they've had thyroid surgery and different types of endocrine surgeries. So Schaffstecks and Trousseaus. Schaffstecks, think about the cheek. If you tap on the cheek, you're going to see movement, kind of tetany almost. And Trousseaus, you put a blood pressure cuff on their arm and they're going to do some weird movements. You can locate a picture of this in your book. And so this goes along with hypocalcemia. Laryngeal and bronchial spasms. Okay, that's a big thing with somebody that has had surgery and is showing signs of hypocalcemia. Tetany and seizures, and then ventricular tachycardia, which is ventricular tachycardia is a very bad dysrhythmia that can lead to death. It means that the heart is extremely irritated. Nursing diagnosis as far as hypercalcemia, we have risk for electrolyte imbalance related to excessive bone destruction. Remember what I said, the calcium is not where it needs to be in the bone. So we have ineffective activity intolerance related to generalized muscle weakness, and then risk for injury related to neuromuscular and sensorium changes. Again, confusion, things like that we're looking at with a lot of these electrolyte problems. And then potential complications, which would be our dysrhythmia and potentially death. With hypercalcemia, the nursing implementation stems from or depends on the degree of hypercalcemia and the underlying condition or cause. So when it comes to mild hypercalcemia, they're going to stop the related medications. They're going to put the patient on a low calcium diet because we don't want any more calcium in the bloodstream. We're going to increase the weight-bearing activity. So, because if you remember back to osteoporosis, if they increase the weight-bearing activity, that's going to help reduce that calcium demineralization from the bones. So with these patients, we want to maintain hydration of 3,000 to 4,000 milliliters a day to promote renal excretion and reduce the chances of kidney stones. And in your book, it mentions that cranberry juice and prune juice are good fluids to give them because it's acidic and it helps to prevent stones. Severe cases, they're going to administer saline biphosphonate and calcitonin to try to get that calcium back into the bones. And then dialysis is used in very life-threatening situations because with dialysis, they'll go in and actually pull the calcium out of the blood system. Okay? And sometimes they might use IV isotonic normal saline as well to help to reduce the calcium. So now let's talk. We went back. Hypocalcemia, just remember back here's your clinical manifestations. And if I were you, if I were 20 years younger and studying, I might put these on, like I said, some flashcards to help me remember each of these things, because this section is a lot of memorization. So with hypocalcemia, we're going to be looking at risk for electrolyte imbalances, okay, related to decreased PTH levels, okay. So if you have individuals that have parathyroid surgeries and things like that, these are our ones that are at risk for hypocalcemia and having the spasms and the tetany and the chopsticks. Ineffective breathing pattern related to the laryngospasms, which is, again, indicative of hypocalcemia. Acute pain related to sustained muscle contraction. Okay, they will have some muscle contraction if they have hypocalcemia. And if you look at the Trousseau sign and how when you put the blood pressure cuff on, what it does to their hands, you're going to kind of see that muscle contraction in that pose. Risk for injury related to tetany and seizures. Okay, and potential complications would be fractures and then respiratory arrest, and at points maybe going into cardiac arrest if they have significant dysrhythmias. The nursing implementations for hypocalcemia depends on the underlying cause, again, and the symptoms. So mild hypocalcemia, they're going to use a diet rich in calcium with vitamin D supplements. All right. Symptomatic, they're going to treat them with IV calcium gluconate, and they're going to promote carbon dioxide retention or sedation to reduce the symptoms of tetany. They're going to change them to a loop diuretic. They're going to change their loop diuretic to a thiazide diuretic. Okay, and then they want to treat any anxiety or pain to prevent hyperventilation, which precipitates hypocalcemic symptoms. Okay, and they want to assess patients post-neck or thyroid surgery for hypocalcemia. Okay, so you're going to see that. That's one of those things that you're going to be assessing them for. You're going to be assessing their airway. You're going to be assessing to make sure they're not having tingling in their lips or chopsticks or Trousseau sign. Going along, the one thing you need to recognize about calcium is its inverse of phosphate. Okay, so usually when your calcium is low, your phosphate is high. Okay, so this is going to show itself right here when we talk about the clinical manifestations of hyperphosphatemia, which is greater than 4.4 milligrams per dil versus hypophosphatemia, which is less than 2.4 milligrams per dil. So with hyperphosphatemia, you're going to see symptoms of hypocalcemia. So go back to your symptoms of what we just discussed. And make sure that you recognize those things. Numbness and tingling in the extremities and the region around the mouth. Hyperreflexia or muscle cramps, so the deep tendon reflexes and the pain. So that, again, they're having the symptoms of hypocalcemia. Tetany and seizures. And then calcium phosphates precipitate in the skin and the soft tissue, etc. Okay? That's some of the symptoms there. And with hypophosphatemia, and I just realized I had a spelling error. No, I don't. Okay, I'm good. Hypophosphatemia, less than 2.4. CNS depression, so we may see confusion and coma. Muscle weakness, including respiratory muscles. Polyneuropathy, okay, and seizures. Lots of tingling, pain, things like that in their extremities. Cardiac problems, dysrhythmias and heart failure. Osteomalacia and rickets, and rhabdomyolysis, okay, which is a breakdown of the muscle itself. So with hyperphosphatemia, what we're typically going to see is we are going to see patients that are often asymptomatic unless calcium binds with phosphate, leading to hypocalcemia. Okay, so that's when we're going to see the symptoms of hypocalcemia. Hyperphosphatemia is often common in patients with acute kidney injury or chronic kidney disease and so what they do with these patients is they'll put them on phosphate binders. You're going to see that a lot in the hospital. So they need to identify and treat the cause of hyperphosphatemia, reduce the intake of foods that are high in phosphorus. So this would be your dairy products, okay, a lot of your dairy products. So think about the types of foods that would include. Cheeses and yogurts and things like that. Oral phosphate binding agents, they may give that as well. Okay, and what that does is it limits the intestinal binding agents, so it increases the phosphate excretion. Severe cases of hyperphosphatemia, they will do dialysis, and then they may have to do some volume expansion and some loop diuretics. And if you get into your reading, it explains this a little bit more. The nursing implementation for hypophosphatemia or low phosphorus levels is we'll see an increased oral intake with dairy products, okay, is what we will do. because we want them to have that phosphorus, or phosphate supplements. Symptomatic hypophosphatemia will have an IV administration of sodium phosphate or potassium phosphate, and we will do frequent monitoring during IV therapy and complications of hypocalcemia, hyperkalemia, hypotension, and dysrhythmia. So hopefully you're seeing that a lot of these electrolyte imbalances typically go hand in hand. When we're correcting one, a lot of times we're trying to correct the other one as well. If you go in and you read in your book, it talks a little bit more about the nursing implementations of hypophosphatemia. So we need to decrease intestinal absorption and increase urinary excretion. Okay, malabsorption, diarrhea, or phosphate binding antacids is typically the cause when we end up with hypophosphatemia. And if we have severe hypophosphatemia, it may be fatal due to decreased cellular function, and it may cause CNS depression, muscle weakness, pain, and respiratory failure. And I've been a nurse for quite a few years, and I have not seen hypophosphatemia. I'd have to talk to some of my ICU counterparts to see whether this is something they frequently see. And if you look in Giddens doesn't go into phosphorus and other things at all. But I wanted to go ahead and put it in here so that you had some insight. Thanks.